Good afternoon and welcome everybody to the CHPR seminar series. For some of you, this is EPI 291 spring quarter. Welcome. We're so glad you're joining us. For other people, you might be joining for CME credit. Unfortunately, this talk will not offer that, but it will offer a lot of insight and interesting, thought-provoking topics. If you'd like to ask a question, you can do the virtual hand raise. You can type it into the chat. I'll be monitoring the chat and letting Dr. Moulin know if there are questions. She'll take questions at the end as well. We are recording so that there's an opportunity for students to watch the talk. If they can't see it live, they'll be able to watch the recording and learn in that fashion. I'd like to start by introducing Dr. Aimee Moulin. She is a professor at UC Davis in the Department of Emergency Medicine and chief of the Division of Addiction Medicine. Dr. Moulin is a co-founder and principal investigator of the California Bridge, or CA Bridge, a statewide effort to expand low barrier access to treatment for people with substance use disorders. Dr. Moulin completed and established a health policy fellowship at UC Davis. She's the past president of the California chapter of the American College of Emergency Physicians. She completed residency in emergency medicine at the Los Angeles County LAC plus USC Medical Center. Today, her talk will be entitled Solving Addiction Through Science, Evidence-Based Treatment for Opioid Disorder. She will focus on evidence-based treatment for opioid use disorder and the low barrier treatment model. She'll present recently published studies on outcomes for patients engaged in treatment through California's emergency departments as part of the CA Bridge program. Thank you, Dr. Moulin, for coming and talking to us today.
Thank you. Really appreciate the opportunity to chat with you. And I'm gonna leave time for questions at the end, but also happy to stop. I'm hoping this will be a conversation, so please feel free to interrupt, put comments in the chat, and hopefully, Jeff, you will let me know that, and we will pause for questions, because I'm hoping that this will be a conversation as we kind of talk about evidence-based treatment for opioid use disorder. And I think a lot of our current system of care for opioid use disorder is based a little bit more on mythology and tradition than actual science. And so we're going to kind of go through some things that might be different than how you think about treatment for opioid use disorder. So happy to chat more about that. I'm going to talk a lot about buprenorphine, which is a medication that's primarily used for treatment of opioid use disorder. And you might at some point feel like I'm a shill for buprenorphine, because I kind of am, but I have no connection to any pharmaceutical company. I do work with the California Bridge program, and additionally have 2 research studies that are really focused on increasing access to treatment for addiction, coordinating between the ED and outpatient clinics, as well as a trial of looking at telehealth as an option for patients to continue treatment for buprenorphine. But no connections to drug companies, God bless them. So this is really kind of what drives me and drives all of my work, which is really access to care. And so this is sort of the mission of California Bridge, and a mission of my work is that all people deserve rapid access to evidence-based addiction treatment. So this is really kind of my reason, my drive, and this will be kind of the goal of everything that we talk about today, is to increase access to evidence-based treatment, which is not always what we offer folks. One other disclosure that I'm going to say is that we're going to talk about studies. And for those of you who are interested in research and public health, when we talk about what works, we are talking about what works broadly across a population, right? So we look at things that work for a population of people, and when you compare different treatment modalities, we talk about what works best for that population. Every individual is different and unique, and so people may have had an individual experience, and their journey through recovery and their individual experience might be different and might not be perfectly represented in the study. These are all valid. So any one individual's experience might have been different than what impacts broadly across the whole population. So just want to say, when we talk about the research studies, we're talking about what works for the largest group of people, has the greatest impact for the largest group of people, but not to discount any single individual's experience. So there's kind of a difference between personal experience and then what works across the population. Okay, so this is kind of like the baseline. This is California. There have been some good signs. We are thinking that the overdose death rate in California and across the nation has started to plateau and potentially even decrease. But one of the pieces is like, good news, yes, but we are still, even our plateau and our decrease is still a wildly unacceptably high rate of overdose deaths. And this is our data from California, hasn't been entirely updated. We do think, my last conversation with CDPH, that we are going to see a little bit of decrease in California. And this is primarily due to the lethality of the primary drug of choice, which is fentanyl. Fentanyl is highly concentrated as an opioid, and it is highly lethal. So it kills people faster than other substances. Other substances that people have used in the past, stimulants, methamphetamines, alcohol, still kill people, but it tends to take longer. So fentanyl, what we see is this high rate of overdose deaths because it is so lethal. And it is more of a marker of prevalence, right? So people have always been using substances, but as we switch and we expand the use of fentanyl, because it is so lethal, we are seeing this really high overdose death rate. And this is really what drives me. So this is old data on the National Survey on Drug Use and Health from 2022. We will see. My last understanding is most of these folks have been fired, so it might not be updated, but this is the best we have. They looked at people who had a substance use disorder. This is going to include alcohol, opioids, methamphetamines. And did you receive any treatment in the prior year? Most people received no treatment. So for me, this is the major driver, right? The problem is access. The problem is that we are not providing any treatment. So the majority of people with a substance use disorder are not receiving treatment, and in particular, not receiving medication treatment. So these are kind of the big pieces that we are going to talk about. Kind of the background for our discussion today is that high overdose death rate, and really this piece around people who have substance use disorders in this country are not, by and large, receiving medical care. So here's this, what we're going to talk about are treatment models, and I am going to focus on opioid use disorder primarily. So some of the different treatment modalities for other substances are different. The key difference for opioid use disorder is really buprenorphine, there I go, which we have highly effective medications for opioid use disorder. This is true to a lesser extent for some of the other substances that we see, alcohol and stimulants. We don't have as effective of medications as we do for opioid use disorder. So we're going to talk about the different treatment models with a focus on opioid use disorder. And then I'm going to talk about California Bridge, which is our program to really expand access to drive that 95% number down through emergency departments. EDs have some huge benefits in that you can walk into an ED any time of day. And so we tried to leverage that open access to emergency departments to expand the number of people who had access to medications. So we really used this low barrier medication first treatment model. So I'm going to go into that treatment model and then to see how well did that work. So there are some recently published studies on the California emergency departments and outcomes for folks who got medications through California EDs. Any questions there? So I just keep blazing along. All right. Okay, so when you all think about treatment for a substance use disorder, you close your eyes and you picture, like, what does treatment for addiction look like? Most of us picture two things. One is an AA meeting in a library basement where folks are sitting around on chairs talking about their lives on a Thursday evening. The other thing that you picture is a residential treatment program up in the hills in Malibu where you are riding horses and communing with nature, right? That is what treatment means to most people in this country. And if I have a theory that if that is how you view treatment, that is not appealing to most Americans. So most people are like, I don't really want to spend Thursday evening with a bunch of strangers in a basement talking about my problems. I don't want to do that. That does not sound like fun to me. And how many people really, honest and truly, can take 30, 60, 90 days away from their employment, away from their social structures, away from all of their responsibilities, and can afford to go to a ranch in Malibu and ride horses. And so part of what I want to talk about is, I think to some extent, those models are potentially responsible for the lack of access, right? Because if the treatment modalities we are offering to people are not accessible to people, we're not all that effective. So the models that are commonly done, the behavioral health interventions, the facilitated 12-step programs, that's the AA model. Cognitive behavioral therapy, which many of you are familiar with, is a common behavioral health therapy, is also effective for substance use disorders. Motivational interviewing, and then contingency management, which is really most effective for stimulant use disorder. Contingency management is a very cool treatment modality where people have random rewards or sometimes escalating rewards in response to a behavior that you want to incentivize. So either decreased substance use or engagement in treatment. So these are the common behavioral health interventions. There is some evidence of efficacy for 12-step programs, cognitive behavioral therapy. So all of them are marginally beneficial, but primarily these behavioral interventions, their efficacy is wildly washed out by the efficacy of medications for opioid use disorder. So for opioid use disorder, we have very effective medications. Interestingly, 12-step facilitation, the AA model, slightly more effective when we're talking about other substances than cognitive behavioral therapy, which I thought is really interesting. We do see reductions in use and improved engagement compared to no treatment and some decreased relapse rates, but these are marginally effective. We get a little bit of efficacy here, but not magic. So this is the study that kind of drove home this point. This was a really interesting study where they did a review of 48 years of research, and this is specific for opioid use disorder on psychosocial interventions. 48 years, they reviewed 305 studies, 54,000 patients, and compared efficacy of their behavioral health interventions to medications. This is for opioid use disorder, where we have highly effective medication. Really didn't find a whole lot of benefit to the psychosocial interventions. So for opioid use disorder, those two models that we think around, the 12-step program, the residential treatment programs, just not really, the evidence is not there to show that they are highly effective for opioid use disorder. This was a pretty damning study. They were, they didn't really beat around the bush very much in their conclusions. This is a direct from the paper, but I think it really is necessary to kind of drive home the point of, for opioid use disorder, we have some highly effective medications. These are the 3 FDA-approved medications for opioid use disorder: buprenorphine, methadone, and naltrexone. The efficacy of naltrexone is not nearly the efficacy of the other 2, so I'm not really going to talk about it very much. Naltrexone is more effective for alcohol use disorder than it is for opioid use disorder. So primarily, I'm going to talk about buprenorphine because it can be prescribed. Methadone cannot be prescribed for opioid use disorder, has to be administered from a opioid treatment program. So the primary medication that we were initiating and prescribing is buprenorphine, because it is much easier to start someone and continue buprenorphine than methadone from the emergency department. Most of our EDs do both, but the primary treatment modality is buprenorphine. Buprenorphine is a partial agonist, so it treats withdrawal symptoms, it prevents overdose, it decreases cravings, but does not have the same CNS effects of a full agonist, like methadone or fentanyl. So for buprenorphine, you have a ceiling on respiratory depression. So buprenorphine is really almost impossible to overdose, doesn't cause people to feel the same CNS depressant. They do not have respiratory depression. So a lot of those CNS, that euphoria, that sedation, we do not see it at all with buprenorphine. Questions? No? Keep going? All right. So this is really the kicker. This is why we see very few impacts from our behavioral health compared to medications. So this is mortality, right? I love buprenorphine is amazing because so many times in medicine, I will give a treatment and we can kind of modify the disease a little bit. Because opioid use disorder is lethal, the medications are effective. Like, you see a mortality benefit. This is enormous. How often can I give someone a medication and see a mortality benefit? Huge. Mortality is such a great outcome because it's like very fixed. You're either dead or you're alive, and it's very meaningful. So this is the best outcome we have for any research study. And buprenorphine and methadone have a huge mortality benefit. So if you have opioid use disorder, your risk of death, and this study was in 2015, which is before fentanyl was everywhere, they said 6.1 times your risk of death. I think it's much higher now because fentanyl is more lethal. That was way back when people were just using heroin. And when we put that individual in treatment with methadone or buprenorphine, your mortality goes back down to about the general population. And we got a question. Yes.
Thank you, Aimee. This is amazing, that giant improvement. Again, I don't treat patients, so I don't know how this works, but when you offer the treatment to people, are they all like, thank you, doctor, I can't wait to start taking this treatment for this issue I didn't know I had?
Yes.
So they all,
I'm going to get to that.
oh, okay.
But just to preview, so there's a myth of treatment resistance where the common myth is people do not want help. People do not want treatment for their substance use disorder. And that's the reason for the 95%. However, when we offered buprenorphine through the emergency department and said, like, hey, did you want help? You have an opioid use disorder. Did you want medications? Did you want a referral? Not everybody started medications, but about 85 to 88% of the people, depending on the study, said, like, yes, I would like to talk to someone. I would like a referral. I would like to start medications. So most people do want help. Whether they are able to go through all of the steps to get onto medications and be stable on treatment, we lose folks along the way. But most people recognize that they want out of where they currently are. Great question. This is another study. This is a comparative effectiveness trial, and they looked at medications. They looked at folks who had overdosed and looked at the non-fatal overdose and the time to their second overdose. So you had a non-fatal overdose, and they looked at the time to your next overdose, this various treatment modalities. And really what you saw, again, medication, so that's that top line, people who received buprenorphine or methadone had a much longer time period to their second overdose, if they had a second overdose at all, than people who were in behavioral outpatient treatment versus residential treatment versus a straight detox without medications. When they looked at people who went just through detox, which we would consider like cold turkey, you just stop your medications, versus no treatment, those people in those groups had the same time to their second overdose. So what that tells me is, like, cold turkey detox, your outcomes are about the same as if I do nothing. So really shows here the benefit to medication treatment, buprenorphine and methadone. So my takeaway from these evidence studies is I need to get more people medications. So really the treatment for opioid use disorder is medications, is access to buprenorphine and methadone. And that was really the driver for the California Bridge model. How do we get more medications to more people? So we had a three-pronged model. Low barrier treatments, you have opioid use disorder, you get medications. The goal was no barriers. You come in and we say, hey, did you want help? They say yes. We say, how about today? Here's your meds. So medications on demand. And then people with lived experience are substance use navigators who provide that connection to community care, and really a focus on harm reduction of that culture of destigmatized access to treatment. So we have a long history in healthcare of providing highly stigmatized care for people with substance use disorders. We really try to do a lot of training and emphasize this idea of harm reduction, of meeting people where they are and offering them treatment on demand. So this is based on self-reported data. So for 5 years, we tried to reach all of the emergency departments in California. We got to most, about 276 to 279, depending upon dropouts, hospitals with bridge programs. 49 of 58 counties across California. And when all of the hospitals were reporting data, we had about 8,000 patients every month seen by seen in the EDs and identified, 3,000 discharged with a follow-up appointment, and 2,300 monthly prescriptions for buprenorphine. So really kind of a high volume, can we get patients buprenorphine? Based on the number of folks who we think are in the ED with undiagnosed opioid use disorder, that's probably about a 10th. So that 2,000 number, if we were getting efficiently to everybody, should probably be closer to 20,000 if we were getting to all the folks who needed us in our emergency departments. I'm going to pause again there for questions. Everybody's asleep. All right. So this is low barrier care. This is really, medications are offered first. Like, you come in, you get medications. Traditional thinking for substance use treatment was, remember that, like, you have to participate in your AA meeting, and are you going to counseling? And if you're going to counseling, then I will give you medications. You have to have all these treatment contracts. There were a lot of preconditions in order to be able to access medication, and a lot of emphasis on, like, are you following up? Have you stopped using? And really a tradition of, like, if you relapse, then you are a bad person and you are out of clinic. Which really, if you think about it, if someone relapsed, that is the moment when we should increase our intensity of engagement with that person rather than pull back and say, like, you relapsed, and so we're not going to give you your medications anymore. At that moment, what we really should do is say, like, okay, we need to re-engage. Yes, we got a question.
So I just want to make sure I'm understanding, again, still not a doctor. Um, it's possible that when somebody comes in and you have a chance of giving them this medication, there might be a group of care providers or healthcare policy experts who say, you really shouldn't give them this treatment because it will actually encourage them to continue to do what they're doing. Wait until they've solved their problem and then offer to help them solve their problem. And then there's another group of people who say, we'll give them the treatment because it seems like that's what they need, even though we're not setting any conditions on them. We are going to assume that they will like being healthy more than not being healthy. Is that a fair way of describing?
Yeah, yes, there's a fair way of describing it. I think there is been a view that people with a substance use disorder, and we didn't talk about the medical model of addiction and how it impacts the brain, but that really the reason you are using is because you are a criminal and a bad person, and so that you must be punished through your treatment process and suffer in order to go into recovery. So some of that is like that detox model of you need to have suffering in order to be able to access treatment. People don't usually say that, but that's kind of the model that we've had of like, you have to go through detox, you have to show that you are worthy of medications. But if you look at the studies, it's really the medications that help folks get into recovery. And so what we look from our research, the research model is medications, that we should get folks onto medications if the outcome we care about is death, because the medications decrease overdose. And the other piece that we often will say is like, if someone relapses, or even if they're continuing to use while they're on buprenorphine, buprenorphine prevents death, death being the outcome I care about. So we should continue to engage that person. I got some more questions.
Yeah, Glorietta, please.
Hi, quick follow-up question. So, in that mix of physician thought, where you have physicians that think providing treatment incentivizes individuals to continue on opioid use, do you see those physicians represented at particular hospitals, or do you see that thought kind of mixed in different hospitals, different communities?
Yeah, I think that it is, well, I like to think about it as sort of the traditional legacy model, that legacy social model of addiction treatment that doesn't necessarily recognize the efficacy of medications. And I think really a tradition in healthcare of providing very stigmatized care to people with substance use disorders, and kind of recognizing, like, to a large extent, criminalization is that the person that I am treating is also by society a lot of times considered a criminal. And so it's kind of those two things mix in to compound, and we provide this stigmatized care. And so a lot of what we did with California Bridge was changing the way that people think about and interact with individuals with substance use disorder so that they can universally offer treatment in a destigmatized way that meets the patient where they are. But it's a great question. And I think it's, work that needs to be ongoing. This was put out by SAMHSA about a year ago, so they agreed with our approach finally and issued what they considered low barrier care. So SAMHSA now recommends this low barrier treatment approach. And so they put out statements around like how people should have low barrier access to care, that there should be no preconditions, and really that medication first model is now recommended by SAMHSA. Actually, I'm going to pause here before we move on to our California Bridge outcomes studies and see if there's any other questions about the California Bridge model. Yeah.
Hello. So I was wondering if there are any negative side effects to buprenorphine.
Buprenorphine?
Yes, because you said
Yes.
it was a semi-antagonist.
So
medication.
buprenorphine, right. So buprenorphine is what we call a partial agonist. So it kind of acts like an opioid in some ways and kind of doesn't in other ways. You will see some people have some sedation with buprenorphine. It can make some people experience some nausea with buprenorphine, but it was generally a very safe medication. So you cannot really overdose on buprenorphine. You can, if you use a lot of buprenorphine and you are 3, or if you combine buprenorphine with alcohol or benzodiazepines, you can be associated with an overdose of a polysubstance user. However, primarily relatively safe. There are it's a sublingual medication. There are some reports of increased like dental disease with the dissolvable sublingual medication formulation. But those are the primary pieces. And so generally, given the harms associated with fentanyl use, buprenorphine is a wildly safer alternative. The other thing that is a unique feature of buprenorphine is that a little bit technical, but it binds that opioid mu receptor with high affinity, which means it will sit on that receptor tighter than any other opioid. So if I have given someone a lot of buprenorphine, bound up all of their receptors, it becomes very difficult for that person to then overdose on a full agonist because there won't be any place for the full agonist to bind because the buprenorphine likes the receptor more. That makes sense. So it is a relatively very safe medication. Great questions. Yeah. Glorietta, see your hand up.
Sorry, one other question. Has there been sort of a cost analysis of individuals who end up receiving treatment and versus individuals who don't receive treatment, overdose, and then the care and cost that's involved with that?
I love it, Jeff. That is so great. I do not have the data here, but but buprenorphine is a very cheap medication. It has been around for a really long time. It is covered by Medi-Cal, and so yes, it is cost effective to treat individuals with buprenorphine. And then you could do some other fun stuff looking at the social consequences of untreated substance use disorder in terms of like healthcare utilization, but also engagement with law enforcement, really the broader societal impacts of untreated opioid use disorder versus a medication that can be prescribed. So very cost effective, but I can't give you those numbers off the bat. But thank you. I should have had them for you, Jeff.
Thank you.
Here. Great question. There is a question around over-the-counter buprenorphine. So I don't have this study up either, but this is the model in France. So France is available, buprenorphine is available at pharmacies and has been for many years. France is the model that we looked at years ago in response to increasing rates of HIV. In France, they did a public health analysis and identified injection drug use as a driver of HIV infection. And in order to treat that, made buprenorphine widely available at pharmacies. And still today, you can get buprenorphine at a pharmacy in France. And that policy change correlated with the decrease in overdoses. It's a very old study, but I think is a really good public health model. To the question of, do I anticipate buprenorphine being over the counter in the United States? Given that we had extra restrictions around prescribing buprenorphine and continue to have a fair bit of stigma, I don't anticipate that happening in the United States, but it would be an interesting policy experiment.
Dr. Moulin, we have an interesting comment. Talon, did you want to go off mute and share your insight from VetMed?
Sure, it's not very super relevant to what you were talking about, but it was just kind of adding some additional context to that affinity binding and stuff with buprenorphine. We commonly use that in veterinary medicine, sometimes as a reversal for some of those opioids that are causing a lot of like dysphoria, just because of that purpose that you mentioned as well.
Yeah, no, buprenorphine is a very interesting, I think, underutilized medication in humans. And so in this case, I think like VetMed is widely ahead, like commonly used in VetMed for pain. And I think in humans, underutilized and has some really unique pharmacological properties. So yeah, we could learn a lot from veterinary medicine. Okay, I'm gonna blaze through. So we looked at, California Bridge, we did a great job of giving buprenorphine. We could do better. There's still more people out there, but generally we got our emergency departments to give buprenorphine. And the question is like, how did people do afterwards? So this was an outcome study of 7 EDs that looked at 464 adult patients with opioid use disorder who were interested in treatment referrals, and followed them for 30 days and looked at 30-day treatment engagement. And what we saw was that patients who received buprenorphine in the emergency department were much more likely, now this is not randomized, it's observational, much more likely to be engaged in treatment in 30 days than the people who did not receive buprenorphine in the emergency department. So really kind of showed that people were able to get into treatment at 30 days. 49%, not everybody was going into treatment, but that is better than the 0 if I was not offering buprenorphine. And the other piece that I think is important to recognize for our emergency department patient population is this is sort of the baseline characteristics of the individuals in that study. And what I look at, I just wanted to highlight some pieces here. Over half had unstable housing. 85% had Medicaid health insurance. 71% had some co-occurring mental health condition. Half were co-using methamphetamines, and about 74% had had a prior buprenorphine exposure. So if you were going to design a study of people who were unlikely to follow up, these are the characteristics you would look for, right? Like this is a patient population that most of us would assume is unlikely to follow up at baseline, just based on these characteristics. So I think the fact that this patient population, one, is interested in treatment, because I think if you ask generally the American population would think that these folks are not interested in treatment. Most of them are. Most of them were willing to start buprenorphine. About half were willing to start buprenorphine in the emergency department and did make it to a 30-day follow-up appointment. So I think part of the recognition is that we are able to engage a population of folks who are not currently engaged in other avenues of care into treatment for substance use disorders. Questions about this? Yeah.
What do you think it means that about 3 out of every 4 have had prior exposure?
I think that was really interesting, and I'm going to go to the next study, which I think is also interesting. I think one, a lot of patients that I have contacted have had prior buprenorphine exposure, often because they have used a friend's buprenorphine. Buprenorphine does have some resale value, so people will purchase buprenorphine on the street from other folks. Studies have looked at people who purchase buprenorphine, use it for its intended purposes of like, I want to stop using. So I consider the fact that buprenorphine has street value a market failure, because everybody who wants access to buprenorphine, I think, should have access to buprenorphine, right? And essentially free through the Medi-Cal program. So the fact that people are willing to spend their cash to access a medication that should be free to them shows that I am not providing them access. Like, everybody who wants access should have free buprenorphine. So that just to me says we're not providing enough access to buprenorphine. But also, I think the other piece, which we'll see a little bit in the other study, is the number of times it takes. Like, it's not just a one and done. Like, you don't start treatments and then continue happily along treatment for the rest of your life. We need to leave that door open, because people enter and fall out and re-enter treatment commonly. And so re-entering and restarting and reinitiating treatment, relapse, is a part of recovery, and that needs to be more embedded and institutionalized into our treatment systems. Sorry, I went too fast. And so this again just compares the population of people who were engaged at 30 days versus not engaged at 30 days were more likely to have been administered or prescribed buprenorphine in the emergency department. The folks who did the best had buprenorphine both administered and prescribed by the emergency department. Those folks were more likely to have been in treatment at 30 days. The next study is one that was recently published in JAMA in 2025 that looked at the cures database. They tried to identify emergency department prescribers in cures, either based by how that prescriber self-identified, but really what they did is they came up with some statistical magic of how to identify a emergency department prescriber as kind of an episodic prescriber of buprenorphine. Like, they tried to identify a cohort of prescribers who were prescribing controlled substances in a very episodic way and prescribing buprenorphine in an episodic way. And they designated those folks as emergency department prescribers. I generally think there's a lot of problems with that. But this is sort of how this study looked. This is how the study defined emergency department visits. So they looked at this group of episodic prescribers, which they determined were ED physicians, who had initiated a patient on buprenorphine through cures, and then they tried to look at who had access to continuous buprenorphine for over 180 days without a gap of 40 days or more. I thought that was a really high bar, particularly as a emergency prescriber. Your continuous buprenorphine without a gap for 40 days, that's a pretty high bar for given the population that we're engaging through the emergency department. However, 1 in 9 achieved continuous buprenorphine, that 180-day prescription, and 1 in 3 did receive a second prescription. They did this really cool Sankey diagram of these folks who were engaged through this episodic prescriber and when they achieved continuous buprenorphine, that 180 days. And one of the things that I thought was really interesting was the number of people who had to get a second and even third prescription from another episodic prescriber before they were able to achieve continuous buprenorphine for 180 days. And so really kind of also drives home that, like, there is a fair bit of in and out, that it's not one and done, that achieving 180 days of continuous buprenorphine can require some back and forth, but also kind of recognizing, like, based on that, we need to do a better job of access, and that people need more ways to re-enter the system, and that there's a huge opportunity of folks who didn't make it to their second prescription, who wanted to start buprenorphine and did not make it to that second prescription, as an opportunity there to expand access to care and really to expand that low barrier treatment network.
Hey, Dr. Moulin,
Other-
there's
Yeah.
a question in the chat about shelf life.
We're missing.
Glorietta, you feel comfortable reading your question?
Sure. So my question is, how long is buprenorphine's active shelf life? Does it expire? And what's the pill frequency that a patient would need to take? So are we talking about a daily dose? Are we talking about when an overdose takes place? I think it sounds like a daily dose, but I'm not sure.
Yes, great questions. So buprenorphine, based on its pharmacology, is recommended to be prescribed once a day, so a daily sublingual. Most of my patients like to take it 3 to 4 times a day. I think the FDA approval and the FDA dosing of buprenorphine has not been updated to reflect the changes from heroin to fentanyl. And so most of the patients report that they like to take buprenorphine 3 to 4 times a day at doses that are significantly higher than the initial FDA recommendations. My way of prescribing buprenorphine, because my goal is for the patient to take buprenorphine, so however the patient wants to take buprenorphine and at whatever dose they want to take buprenorphine is how I prescribe buprenorphine. So in this case, like my goals for the patient and the patient's goals are perfectly aligned. So if they would like to take it 4 times, 5 times, 6 times a day, that is how I prescribe it. And I give them the dose to which the patient feels that their symptoms are controlled and they no longer are craving fentanyl. And that has been for 3-4 times a day. There are also long-acting injectables. So you can get a weekly or monthly shot of a long-acting injectable buprenorphine, which has the added benefit of not having to take daily or 4 times a day medication. I do have some patients who take the long-acting injectable and take sublingual buprenorphine, but again, my view on this is the right dose is the dose that the patient takes. Other questions?
Thank you.
So back to, this is really my goal, rapid access to evidence-based addiction treatments. And hopefully, as we've kind of your takeaway that I was hoping to give you is that low barrier access is really the key to continue to drive overdose deaths down. And that for opioid use disorder, really the key to decreasing death is access to medications. And so really my goal is that how do we coordinate and give more folks access to buprenorphine and to improve their transitions to outpatient care so that we are losing less of those individuals are able to get that second, third, and then ultimately that 180 days of continuous buprenorphine. And I'm going to open it up for other questions. We have about 10 minutes.
Fantastic. Thank you, Dr. Moulin. We have 10 minutes for you to ask questions to Dr. Moulin. You can raise your hand with your camera on so we can see it. You can do the virtual hand.
I see, I'm opening up the chat. And then what is the duration of treatment with medication? So generally, there's long and short answer for how long you need to be on medications. The short answer is about 2 years. So after 2 years, if someone discontinues buprenorphine or disengages in buprenorphine treatment prior to 2 years, they are at a higher rate of overdose than someone who is continued for at least 2 years. There's also been some fMRI studies looking at brain activity. And after about 2 years, the abnormal brain activity, becomes more normal. So about 2 years is what we think it takes to recover. However, the duration really is like however long it takes. So if there is a patient who is stable on buprenorphine and being on buprenorphine or methadone allows them to maintain their social interactions, to have a job, to meet their social responsibilities, to not use, great. I don't see a reason to discontinue early. So the answer is really individualized in that case of like, however long that person needs to be on the medication in order to meet their goals and their social engagements and those responsibilities is the right amount of time.
I have
Other,
a question.
I'm trying to flip through the chat and see if we haven't gotten to anything.
Oh, Alan, would you like to ask your question? I see your hand up.
Yes, thanks for the presentation. This was really interesting and great. One thing I was wondering about is that we do see, I feel, well, human healthcare is not my area, but just general understanding is that we do see patients lean towards opioid addiction based off of chronic pain, and there's that pipeline of kind of getting them into that from that issue. Do you see this method of buprenorphine care as addressing enough of their pain requirements and analgesic care that they need in order to get them off that addiction?
Yeah, great question. Two things. I think earlier in the opioid epidemic, we saw a lot of folks switching, like they were on full agonists, so people who were being given prescribed opioids. And then, due to some maybe misguided guidelines from the CDC, rapidly down titrating their prescribed opioids, and those folks sort of relying to non-prescribed opioids. Currently, I think there's a fair bit of just de novo fentanyl use because it is so highly prevalent in our society. However, buprenorphine is also effective for pain. And because it has less risk of overdose, less respiratory depression, we are seeing buprenorphine used for pain, including chronic pain, pretty regularly. And at higher doses and increased frequency, we are seeing buprenorphine work both for opioid use disorder, as well as some patients who have like a primary pain disorder are treated pretty well with buprenorphine. So although there are some folks who still need full agonists, and I am not primarily a pain physician, I do know that it is effective as well for pain. And I think probably underutilized.
Thank you.
Thanks, Talon. We have basically 5 minutes left, and we have 3 people with questions. We have Irina's question in the chat, we have Courtney, and we have Stephen. So I'm going to load you up with questions, Aimee, and then give you the floor. Is that okay?
Yeah.
Irina, did you want to go off mute and read your question, or do you want me to read it?
Yeah, I can read it. I'm just wondering, because the dose is so unpredictable in a way, because it seems like everyone responds differently to it and needs different amount. In my mind, it needs some sort of a level of support to these patients. So that's kind of where my question is. How do they deal with all these ups and downs, taking 1 time a day, but then twice a day, maybe 5 times a day? How does it affect their life? Who is responsible for supporting these patients as they're taking this medication?
Thank you, Irina. Before you get to that, Aimee, I'm going to harvest 2 more questions, one from Dr. Lyles.
I'll let Aimee answer that. It's okay. Go for it.
Okay, and the last one to harvest will be from Dr. Henry.
I don't have any question.
Perfect. Super. So we got 3 minutes left, Dr.
Yeah.
Moulin.
In terms of like dosing for medications, again, like however the patient wants to dose their medication is how I prescribe it. So I allow the patient to be the driver. Patient support, so every patient is different. Some patients do better and want a highly structured outpatient treatment environment. And so those folks who benefit from that highly structured treatment environment, we try to refer them to outpatient care that meets their needs. We also do not want being engaged in that structured treatment environment to be a barrier. So if a patient is not yet ready to engage in a highly structured treatment environment and really just would like access to the medication, we provide access to the medication. So the goal is to both have that structured treatment environment be an option for individuals who are ready for that, but not a barrier. Recognizing that the outpatient treatment milieu is not anywhere at the spot where it can accommodate the full need out there, right? And remember that first slide, 95% of people don't have access to treatment. So recognizing that even given the expansion in outpatient treatment, we are not anywhere near meeting the needs of our current patient population.
Thank you.
Thank you. Thank you very much, Dr. Moulin. Thank you so much for coming and talking to us about your research. If we want more information or to follow up with you, what's the best way to get in contact with you if we're not sending spam?
Yeah, probably my Gmail. So I'm going to put my Gmail email in the chat because I am better at responding to my Gmail email than my UC Davis email.
I can vouch for that. Aimee, thank you so much for talking to us today. You can see from the questions and the thought-provoking discussion, you've inspired us to think about different ways to help people. Thank you, Aimee. Final thoughts for today?
No, really appreciate your time and your questions. So thank you, everyone.
Super. Thank you, everyone, for joining. We're so glad you could be at the CHPR seminar series. If you have time and interest, next week, April 16th, we'll hear from Dr. Brittany Catterton. She'll be talking about does haste make waste, prevalence, and the types of errors reported after publication of studies of COVID-19 therapeutics. Thanks again, Dr. Moulin. Looking forward to seeing you all next Wednesday. Take care, everyone. Have a good rest of your day.